Okay, so another question comes up and says that if a family has a son with hyperinsulinism and has a daughter with hypopituitarism, could it be possible that in fact they both have hyperinsulinism and the diagnosis is incorrect? And that's indeed possible. And like I said, I've had a patient exactly like that. The only difference was is that we didn't have a second child who had the disorder. It was just that the story didn't sound quite right. In other words, when the child would have low blood sugars, they'd go into the hospital and get some cortisol, but the blood sugars wouldn't quite come up, and so we were suspecting a problem. So if you have hyperinsulinism in your family, the chances of also having another very rare disease are very unlikely. So the chances of having diffuse hyperinsulinism is 1 in 50,000. If your family has that, the chances of having another child with it are 1 in 4. But the chances of having a child with hypopit is 1 in 50,000. So it is more likely statistically that you have the 1 in 4 disease causing your hypoglycemia, not the 1 in 50,000. So of course it's possible that you could have horrible bad luck, but it's more likely. So for that person, Carolyn, I would say yes, I do think you need to think about hyperinsulinism in your second child, and certainly test. If your first child has a genetic mutation that you know, then the simple thing is test the second child. If they don't, then your child needs a fasting study. Okay. The next question is from Karen, and it asks, is it normal for hyperinsulinism children to have puberty early? Well, that's a very interesting question, because inherently there is nothing about having elevated insulin levels and low blood sugars on its own that causes early puberty. The problem is the 20% of children who have hyperinsulinism who have some degree of brain damage, be it seizures, mental handicap, cerebral palsy. And the issue is that any of those things that affect the brain can trigger early puberty. So it would not be unreasonable to conclude that if you looked at 100 children with hyperinsulinism versus 100 children in the population, that probably 15 to 25 of those hyperinsulinism kids will have some form of neurological problem, be it developmental delay or cerebral palsy or low muscle tone or seizures. And of those kids, they have a higher likelihood of going into puberty early. Now, what's the definition of early puberty? Early puberty in girls is described as having breast tissue, pubic hair, and a growth spurt before the age of 8. And in boys having penile development, testicular development, and accelerated growth before the age of 9. A lot of kids, for example, will have a little bit of body odor, or they'll have a little bit of pubic hair development, but not true puberty, and that's called adrenarche, and that's very common in the population. So about 10 to 20% of normal children will have a little bit of body odor or pubic hair before they go into puberty anyhow. And so that's quite common and is not precocious puberty. That's what we call adrenarche. So overall, when you take both of those features, one, the normal variations of puberty, and two, the increased risk of brain damage in our hyperinsulinism children, it is not surprising that we see early puberty in a bigger bunch of hyperinsulinism kids. Now, can anything be done if you go into puberty early? Absolutely. So girls who start puberty before the age of 8 need an investigation to prove that A, it is puberty, B, that it's puberty that's coming from the brain and not because, say, they have a tumor in their ovary or something, which would be very rare. And if that's the case, then there are drugs that we can use in this country. The two main drugs we use are depo-lucron and histrelin or suprelin. It's an implant that goes into your body for a year and suppresses puberty. In Europe, they have different drugs, nafarelin, and there's a couple of other drugs that they have. I can't remember. I used to practice in Europe, but it's a long time ago. So there are drugs that can be used to stop it, and you should talk to your endocrinologist about it. Okay. We have a question about the side effects of diazoxide and diaryl. So the answer is the diaryl has very few side effects. That's chlorothiazide is the generic name, diaryl is the brand name. It is a diuretic, and its biggest side effect is it causes potassium loss. And so some children on diaryl need to take potassium supplements. Some doctors would just recommend doing this by diet, such as eating bananas once a day, or some will actually go on a potassium supplement. For diazoxide, the major side effects are the cosmetic side effect of excessive hair growth. And this is hair growth that is total body hair growth. So this is not sexual hair like pubic hair and underarm hair. This is the normal hair on our body growing faster. So it's the hair in the arms and the legs and the back and the stomach and on the head. And so that's the number one side effect, is that almost everybody who's on more than 5 to 10 milligrams per kilo per day of diazoxide will have excessive hair growth. Another side effect when you start diazoxide is that it increases both sodium and water retention in the body, which causes edema or fluid overload. And so when we start out babies on these drugs, we're very careful. We have to watch their weight and make sure that they don't go into congestive cardiac failure from fluid overload. In the longer term, the biggest side effect of diazoxide is low white cell count. And so these are the cells that fight infection in our bodies. And so if your white cells drop, in particular your neutrophils, it can impair your body to fight infection, and this can be a problem. And the second thing it can do is it can lower the platelets in the blood, and the platelets are the things that help clots form, so it means you can be at increased risk of bleeding. Now, most children who are on diazoxide will have a complete blood count, a CBC, done anywhere from 1 to 4 times a year, depending on what dose they're on and how old they are. And your doctor will be looking for both your platelets and your white cells to be normal. But the thing to remember as a parent is that if your child gets a bad infection, you need to tell your pediatrician that they're taking diazoxide, and that can lower the white cell count, and do a blood test to make sure that's not the problem. And lastly, the diazoxide can cause liver dysfunction. And so probably about once or twice a year, a liver function test needs to be done on patients on diazoxide. And then, of course, any drug can cause an allergic reaction in anybody. So just like an antibiotic can cause an allergic reaction, so can diazoxide and diarrhea. So that would be manifest as fever and rashes on the skin. And so anybody taking any medicine, if they get rashes on their skin, needs to tell their doctor that they're on a medication, because it could be that medication causing an allergic reaction. Did anyone else have any questions here about diazoxide? Nope, we're good. So the reader says, can diarrhea make the side effects of diazoxide worse? The answer generally is no. In fact, it makes the water retention better. And so oftentimes that's the reason why people are put on both of them. And it does sometimes, in some people, help the glucose control. So in some people it makes the blood sugar control a little better, but not everyone. Okay. Sarah wants to know, does Dr. Thornton have anything interesting to say about puberty? That's a whole nother day.
Sarah.
So hi, Sarah.
Sarah Healy.
So firstly, if your children are approaching puberty, God bless you. I have 4 in puberty at the moment, and that's why my hair is going grey. So there are a couple of things about hyperinsulinism and puberty. Number one is that during puberty, there are a lot of different hormone changes in the body. And so those hormone changes tend to cause what we call insulin resistance. So insulin resistance means that your insulin is not working as well as it should. Now, in normal, healthy people, our pancreas is able to make 10 to 20 times more insulin than we need on a daily basis. And so if during puberty we need to make twice as much insulin as on the normal time before puberty, then our body is able to make more insulin, and it's not a problem. If you are an obese teenager, and obesity causes insulin resistance, and so the heavier someone becomes, the more insulin their body needs. So if you get to be very obese, let's take a 200-pound 14-year-old girl, well, her body is going to start to need to be making 5 times, 10 times the normal amount of insulin, and eventually there comes a point where you're not able to make any more insulin, you keep gaining weight, you get more insulin resistant, and you develop diabetes. So the reason why this all is important in hyperinsulinism is that if you've had diffuse disease, for example, and you've had 98% of your pancreas removed, you're only able to make 2% of your insulin. And so when you go into adolescence and puberty, now you might need to be able to make double that, and suddenly you can't. So now you have this really unusual problem, which is that if you eat too much sugar in your diet, your blood sugar will go high and you're not able to make more insulin to bring it down. But if you don't eat anything at all, your blood sugar will go low because your body still is making insulin when it shouldn't make insulin. And this is very difficult to treat. So first of all, we usually start off by restricting the amount of carbohydrates. So we get the kids to go on a lower and lower carbohydrate diet, carbohydrates being sugar, to try and avoid the highs. But many patients who've had surgery for hyperinsulinism will eventually need to go on insulin for diabetes. And that's very difficult because a typical diabetic takes 4 to 6 shots a day, one dose of insulin that lasts all day long, that covers their body when they're not eating, and then they take smaller doses of insulin every time they eat, rapid-acting insulin, to cover the needs of the body when they eat. And the problem with kids with hyperinsulinism is that they're already making a little bit all the time, and so sometimes they just need the short-acting insulin to cover their meals, and that's very difficult to treat. And that really, if you get into that point, you really need to see an endocrinologist who's had a lot of experience treating not just diabetes, but diabetes in patients with hyperinsulinism. Because even someone like me, who's probably seen a couple of hundred kids with hyperinsulinism, we struggle because this is very difficult. A lot of patients like this go on insulin pumps because insulin pumps allow you to be able to give little tiny doses of insulin very easily without having to take shots, and are often the best way to manage it. So puberty and hyperinsulinism has got two issues. One is, as we mentioned earlier, the fact that many kids go into puberty early if they have hyperinsulinism because of the brain damage issues. And the second thing is that if you have had surgery and you've had most of your pancreas removed, the insulin resistance of puberty can trigger you into diabetes. And so those of you who've had 98% pancreatectomies will probably remember that the very last thing we said to you before your child left the hospital was, do not pudge up your child and sort of feed him up into obesity, because it will come back to hurt you later on when they're adolescents. So, did I tell anyone that? You probably forgot like everything we tell you, right?
No. It's been 9 years, but I still remember vividly.
Okay, so now we have Georgina has a question. And Georgina, you're not too late to ask your question. She's describing her child Tilly, so let me read you her little story. So Tilly was born with diffuse hyperinsulinism confirmed by PET scan and responded to 5 milligrams per kilo of diazoxide, which she says is a low dose, and she's correct. And she goes on to say that Tilly's hyperinsulinism got worse, or she stopped responding to diazoxide. She ended up being continuously fed at night, bolus feeds during the day, eating a lot of food, and ending up on a huge dose of diazoxide, 24 milligrams per kilo per day. And at 23 months of age, she had a partial pancreatectomy. And she says, do I know any other cases like this? Well, the answer is yes. We do see some children who appear to be somewhat diazoxide responsive, but as they go along, their blood sugars get a little bit more difficult to control and need a little bit more medication. And eventually you get to the point where the families realize that the risks of a hypoglycemic episode happening is so great that even though they're doing a great job of continuous tube feeds and doing everything, that the risk of a low blood sugar becomes greater than just continuing to wait and watch, and so they'll go and have a partial pancreatectomy. The problem is that taking out 50% of your pancreas is not going to make any difference on your blood sugar control. So if you have diffuse disease, you really have to commit to the 98% pancreatectomy, because taking out 50%, you might as well have done nothing. And then, of course, you run into the problem of diabetes later on in life. And so this is one of the areas where there are two schools of thought amongst pediatric endocrinologists. One school of thought says that, and I have to say I'm a little bit on this side, that if you're not able to maintain a safe home program, then you probably ought to do the surgery up front. You may get into diabetes early on, but it's easier to manage diabetes than hyperinsulinism. And you do have the long-term consequences of diabetes, but we're learning a lot every year. So for example, we now have drugs that will stop the blindness of diabetes, providing, of course, you take care of your diabetes. So every year, the research in diabetes is 5,000 times greater than the research in hyperinsulinism. So we're seeing more and more advances being made in the management of diabetes. So I'm thinking 10 years from now, we'll have much better ways of treating diabetes than we're going to have of hyperinsulinism. So I'm in the school of thought that says the brains in babies under 5 years of age are so susceptible to permanent brain damage that I'd rather be more aggressive when they're babies and run the risk of long-term complications of diabetes, which we might be able to fix, rather than have low blood sugars when we're a baby, because let's say, for example, that you're doing everything right. You're feeding the baby continuously, he has G button in, everything's going good. In the middle of the night you have a power failure, or your pump disconnects and the tube comes apart and your baby suddenly has a low blood sugar in the night and happens to get brain damage. Firstly, the mother is going to say, oh my God, I did this to my child, so there's this horrible guilt that you've got all this responsibility to keep the child's brain healthy and safe, and if a mistake happens, it's my fault. Of course it's not your fault, but show me a mother who wouldn't even think that themselves. Of course, everyone is guilty no matter what happens, and of course it isn't your fault. How can you know? So for that reason, I'm in the school of thought that says, while the brain is so likely to get brain damage, we've got to manage it aggressively. But then there are the people who say, well, a lot of families can do that. They're able to do the continuous feeds all day. You know, this therapy came primarily out of Israel, where you've got large nuclear families. You've got 7, 8 kids per family. You've got all your friends and relatives around, where marriages don't go into divorce as they do in the United States. I mean, the divorce rate in the United States is 50%, and if you have a child with a chronic illness, it goes up to 80 to 90%. I hate to tell you guys, but that's the facts. And here people live long ways from their family. In Israel, everybody lives right beside their family. So you've got two different cultures. You've got a culture of massive family support in one place, and a culture where we're on our own. Like I, for example, don't have a relative within 1,500 miles. And so when things happen in my family, we're on our own. And so I think the circumstances on which conservative management was developed in Israel are completely different than over here. And so I think you have to think about it very hard. Is there a right way to do it or a wrong way to do it? The answer is no. You have to tailor that decision to every family, and then you do what's right for that family, and you work with the family. And if they choose one way, you do your best that way, and you give them support. If they choose the other way, you do your best that way, and you give support.